for medications, before you can calculate a dose, first you have to have a provider order. It needs to be written for the right patient. It needs to be the right drug. It needs to be the right dose for age, weight, situation, the right frequency, how often will it be administered, the right route, how will it be administered, the right time. This is more about administration itself, or the distance between doses. So maybe it was ordered 3 times a day. Do we want to make that every 8 hours, or does it need to be with meals? The right assessments, and of course the right documentation. So the right assessments, is this the right drug for the patient based on their physical assessment? So here we have an order, and it's on a specific patient chart, and this patient has been having itching anytime they have contrast, no actual hives, or aka urticaria, just itching. So the physician has ordered Benadryl diphenhydramine 25 milligrams IVPush every 4 hours PRN. So PRN is as needed. So we have the right drug. We have both our trade and generic names. We have our right dose. We have our route, and we have our frequency, and it's as needed. So if we're giving the first dose, so this PRN actually has to be defined, PRN itching. So anytime PRN is written, it has to have the PRN reason with it. So we have PRN itching. So the patient hasn't received the contrast yet, but they're requesting that they get the dose before they receive the contrast. Is the patient itching? If the patient says no, this criteria has not been met. So we cannot give the medication as it's written. So we would have to call the provider and request a now dose in order to give this to the patient prior to the procedure. Because the way it's written, it does not qualify. The assessment doesn't match the cause for the drug. Now, depending on where you are at and where the provider is at, say they're driving down the road, they are not able to put this in the computer in the patient's electronic health record. You give the now dose. All the parameters are met. Certain assessments might need to be done. So we know that antihistamines should not be given to certain people. In some instances, we are looking at risk versus benefit. So that may pop up when you're putting the order in. So this would be considered an override if this is contraindicated in that particular patient. So override, and then you choose benefit outweighs risk. So maybe it just triggers, so are they awake? Are they alert? What about their respiratory rate? Because this can have an effect on the respiratory rate. It can cause sedation, of course, and you're giving it IV, so it's not a delayed response. So just be sure that their assessment supports viability of the patient should they receive the medication. So you give the ×1 dose. Then you do the procedure, CT, abdomen, 2 hours later when they're back in their room and they're complaining of itching. So if you did not document that now dose, then the nurse doesn't know it was given. We've changed shifts, so whoever you called and gave report to earlier has already gone home. So that's the reason why documentation is so important, so we don't duplicate and give a medication too soon or repeat it. So now we need to get to dosage calculation. So our order is diphenhydramine 25 milligrams IVPush now and every 4 hours PRN itching, and we threw nausea in there. So what you have provided, and I kind of abbreviated diphenhydramine so it fit on my label, is 50 milligrams per milliliter, and you have 2 milliliters in this vial. So we need to set up how we calculate that, which, you know, most of us in our brain have already calculated that. But let's make sure we follow the format. So we're going to do dose ordered over dose on hand times how it's provided. So we know that equals 25 over 50. And then 25 divided by 50, we know that 50 will go into 250, or you can mark out your zeros. 5 will go into 25 5 times. So we know our dose is 0.5, but we don't call it 0.5. We always put a 0 in front of a decimal when it comes to medications in the healthcare setting. We never put a 0 after decimal because it might not be seen. But anytime there's a 0 in front of a number, then we kind of suspect that there should be a decimal there, and maybe the writer just didn't press hard enough, so it gives you a moment for pause to kind of understand what might be going on. So we are going to give 0.5 mLs. So our syringe, depending on where you work, if your dose is less than 1 mil or less than 1 mil, then they recommend that you use just a 1 mil syringe so you can get more accurate dosing. So a lot of your syringes do not come with a needle. In healthcare, we use a blunt fill needle for drawing up medications, and that is also your syringe cover. So we'll say this is a 1 mil syringe. So you'll have your little increments, so that'll be 0.5 and 0.75 and 1, 0.25 and 0.1. So you'll have increments of tenths, or on larger syringes it will be quarters, and on larger syringes it'll be 1 mil, and probably still have your quarter marks. So we're going to pull our plunger back to 0.5 because we want to inject air if this is a multi-dose vial. Now for some things we are still using a multi-dose vial, but the recommendation to keep strict medical asepsis is to have single dose vials. But you still want to put air in because that helps facilitate removal of the medication without creating a vacuum in your vial. And if you're not paying attention and holding your plunger nice and steady, it will pull your medication out of your syringe before you get the needle out. So you have to, if you put the air in, then you don't run into that vacuum issue. So you'll inject that 0.5 air into your vial. Now you are going to, even though there's a cap on here, it is not a sterile sealed cap. This is just a cover, so that you know that the medication has not been tampered with. So you'll pop that off, and you need to scrub the top of the vial for 15 seconds with alcohol. And if you're not going to be drawing it up right away, leave your alcohol pad on top of your vial. That way you know it's clean and no dust is falling on it. We always have dust in the air. If you ever look through a light beam shining through a window, you can see the dust floating around, and in that dust is microbes, and yeah, we don't want to do that. So cover it with your alcohol pad. Get your syringe ready. So you're going to put your syringe straight, your needle straight in, okay, and then you're going to inject your air. Then you're going to invert your vial, so you're going to turn that upside down. You injected your air while it was right side up. So when you invert it, make sure the tip of your needle, the bevel of that needle blunt, is in the actual liquid. And then go ahead and pull your dose back. Pull your plunger back past your dose, because these dry syringes, the medication doesn't necessarily adhere very well. So if you pull back past your dose, then you're priming that syringe with liquid so that it gets rid of the air bubbles a little bit better. And then push that air out and back into your vial. You may need to tap your syringe first to get all the air up here. because you have the vial up in the air and your needle's inside the liquid, and you're going to make sure you get your right dose. Okay, and then you can remove your needle, and you want to leave your needle cap inside that package. Remember, with plastic side down, paper side up. And then you can come in at an angle and scoop your needle. And if you miss it, that's fine. You've kept the inside of that package nice and sterile, so you've not contaminated that blunt needle. And we just go ahead and scoop it up, and then you can press down to click it into place. You can leave your wrapper on if you want to. I usually do. If this is not drawn up at the bedside, then you must label it. Okay, so you're going to put the diphenhydramine, and a lot of them have some pre-filled stickers that you can just put on your syringe. 0.5 milligrams, which is, milliliters, which is 25 milligrams. Your date, time, and initials. Okay, you can put your room number on there if you have a room number, and that way, if it gets misplaced, somebody knows where it was supposed to go and find whoever is responsible for it. Because it may be a controlled substance that might need to be wasted or witnessed waste. Now, when you're giving an IV medication, we're also looking at, is it in dilution? Compatibility, and then rate of admin. So, does the medication need to be diluted? The Institute for Safe Medication Practice pushed several years ago to get the FDA to set rules on medication manufacturers, pharmaceutical companies, that medication come in dilution. Because each time we are accessing that medication, it increases the risk of contamination. So, it's not recommended that we dilute anything. You're still going to see some that dilute because they want to have a better control on the rate of admin. Using a smaller syringe is acceptable so that you can pace your push. Compatibility, most everything is compatible with saline. Some things are not compatible with all IV fluids. Valium or diazepam is not compatible with anything. It does not precipitate right away with your normal saline, so you can use normal saline for flushing before and after. So you want to assess your IV site. Yeah. So you may or may not have blood return, and that's okay. It is a foreign object, and foreign objects the body attacks, so you may get a little bit of fibrin, which will inhibit the ability to pull because it creates a little flap on the end of that catheter in the vein. Sometimes you can use gravity or a tourniquet to distend that vein, and then you'll get blood return. Some medications demands that they have blood return, because if that medication ends up in the tissues, then it can cause necrosis, death of the tissue, and tissue sloughing. So you are going to want to make sure that you have blood return on certain medications that are considered vesicants. And vesicants cause extravasation. And you can remember that because vesicants starts with a V, and extravasation has a V in it. Regular fluids that are not vesicants will infiltrate the tissue. So think IV fluid and infiltration. Both have F's. And a lot of your medications are not vesicants, but they may still be irritating in the tissues, but not actually cause tissue death. So you assess the IV site. It is clean, dry, intact, patent, flushes easily, brisk blood return. There's no redness, edema, swelling. The best way to say that is that it's benign. So that insertion site is benign. So rate of administration. So how fast does that medication need to go in? Speed of your push. Most medications say 1 minute, but you can look that up. 2 minutes, 5 minutes. If it's more than a 5-minute push, we might consider doing a syringe pump, or if pharmacy wants to send it as an IV piggyback. We flushed our site. Now we're going to give our medication, and our medication says to give 25 milligrams over 1 minute. So it's half a mil. So 30 seconds would be a quarter of a mil. 15 seconds would be a quarter of that. So we know that we would give 0.125 ml. 0.125 ml every 15 seconds. Okay. So the problem herein lies in that volume. So the IV catheter, depending on the size, holds a certain amount of volume. So let's see, an 18 gauge. It doesn't say on the label how much volume that holds, but I would say that it's at least 0.1 mils. So the IV catheter itself, 0.1 mils. And then usually your IV saline lock injection cap tubing combo, those can be anywhere from 0.3 to 0.7 mils, depending on the inner diameter of the tubing. So you can tell how thick the tubing is. But the packages on those saline locks will tell you exactly how many mils it is. So you add that together, and we know that 0.8 mils, which is more than our medication, is sitting right there when we're done pushing that medication. So we also need to push our saline flush, at the same rate for at least 0.5 mils. Or else you're giving them that entire medication as a bolus. Because the medication, by the time you're done pushing it, if we have that much space, hasn't even reached the patient yet. So your flush that's following that medication is the medication rate. But let's say the patient is connected, their IV is connected to IV fluid, say normal saline 100 mils an hour, and the pump is pumping that in at 100 mils per hour. These are your injection ports, and this is your patient's arm IV. So it's connected to your patient. We always use the injection port closest to the patient, and these are all lure locks, so your syringe will screw right on the end of that. So most facilities are using Curos caps or some form of alcohol saturated caps. And basically this keeps that port clean but not scrubbed. So you will still, if they have a Curos cap, then you scrub for 5 seconds, and no cap, scrub for 15 seconds. Because we do not want to introduce whatever's sitting on that cap or within those threads into the patient's vein. So it is recommended that the pump be paused. After you scrub, you're going to saline flush, minimum 2 mils. This little injection cap can hold on to drug residue if it's not flushed afterwards, and some nurses don't flush. Anesthesia may not flush. So always flush before with at least 2 mils and after your medication. We always called it SMS, so saline, med, saline. But what you'll see is that a lot of people don't pause the pump. If it is a medication, a fluid that's compatible with the medication you're administering, so your saline flushed before, then you can just flush that at normal. This is also gives you an opportunity to assess for patency, blood return, and you scrub that injection port for 5 seconds in between each connection. If you lay that down, then you have to scrub it for 15 seconds. So holding on to it so that it doesn't touch anything is ideal. If you lay it down, then consider it contaminated. If you turn your back on it, it is contaminated, and that requires a 15-second scrub. We only use one syringe one time, so even if these saline flush syringes are 10 ml, once you remove that, it is trash. You need a second 10 ml syringe of saline flush. One syringe, one time. And the idea is these threads, even though you disinfect them, they still have microbes on them. So when you remove that syringe, there are microbes embedded into that lure lock, and the fluid allows them to travel into that syringe. So one syringe, one time. Because when we disinfect, we can only reduce the number of flora. We cannot remove all of it completely without running water. Sterilization requires heat and or gases. With that said, one syringe, one time, and flush before and after your medication. Okay, so let's talk about calculating that flow rate on an IV bag that has no IV pump. So this is called drip rates. Now each tubing has a drip factor, and it will say on your tubing package what that drip factor is. And a drip factor means how many drops equals 1 ml. So I've seen 10 drops per mil. I've seen 15 drops per mil. I've seen 20 drops per mil. And then 60 drops per mil. This is the best just because it makes it easier to calculate your drops. And you'll also see this called micro drip tubing, referred to as micro drip tubing, because it is the smallest drop. So you do need a second hand, either on a clock wall, ideally on your watch, because you will have to hold your wrist up here and watch your drip factor, because it'll be dripping here. Now, when we prime tubing, you squeeze this flow chamber, and there's a fill line that you bring that to. So you don't want to fill this drip chamber too full, because then you won't be able to count your drips. And there is a way to empty it, and I can show that to you in the lab. So let's say that our previous order was normal saline at 100 mils per hour. Our bag has 1,000 mils in it. We know that it's going to last for 10 hours. Okay. So in order to figure out how fast we're going to drip that so that the patient gets ideally 100 mils per hour, we have to know which tubing we're going to use. So if we use the 60 drop tubing, that makes it real easy, because we just have to watch it drop. So, and we calculate it out to 1 minute. And then we count for 10 to 15 seconds. and make any needed adjustments, because to stand there for 1 minute and count drips, it's going to take you forever to regulate that, because you just have a little roller clamp down here that you're increasing or decreasing your drips by. So we have to decide how many drips do we need to get 100 mils in that patient per hour. So if we have 60 drops per mil, we're going to take our rate per hour times our drip factor, and then we're going to divide that by minutes in the hour. So that equals 100 drips per minute with the 60 drop tubing. So let's say we only have 15 drop per mil tubing. So we're going to take our rate times our drop factor, and we're going to divide that by minutes. So 25 drops per minute should give us 100. So that would be 12.5 drops in 25 seconds. Approximately 6 point. You can't get a point of a drop or a partial drop. So we know we're going to need to do 5 to 6 drops for 15 seconds. Because with gravity, we're in the ballpark. So if that patient stands up, then their rate will decrease. So the closer their IV site gets to the drip chamber, the slower it's going to drip. The further away, the more gravity that's added, the faster it will drip. So you want to make sure it doesn't go in too fast, especially in your young and old. So you want that to be as far away from the patient, higher than the patient's IV site when you set your drip factor, because it's better for it to go in a little bit slower than too fast. Now there is more than one way to calculate your drip rate. Some people want to know, okay, how many mils per minute do I need? So if we're doing 100 mils an hour, how many mils is that per minute? So that would be dividing 100 by 60. So 6 will go into 10 one time, of course. And it'll go into 40 6 times, carry over. So it ends up being the 1.66667 or something like that. So we want that many mils per minute. So if my drip factor is 15, then I can do 1.6667 times 15 equals 25.0005. So it just depends on how your brain works, which way you want to work it, as long as you get the same answer. So the main thing is, in the end, we end up with safe care, no contamination, no med errors, no injuries, no fluid overload, and patients that are happy with our care and want to come back and see us because we kept them alive and made them feel safe.